Hello and welcome to today's webinar, Quality Decoded HEDIS Public Comment. I'm Cassie Yazzo, VP of Product Marketing here at Cotiviti. Thank you so much for joining us today. Before we get started, I wanted to run through some quick housekeeping items for today's webinar. First, you can resize and move all the windows you currently see on your screen, including the slides and presenter video, to find the layout that works best for you. Next, we have multiple options for you to reach out to us during the webinar. Along the top navigation, you'll see our Q&A button, which you can use to submit questions at any point for your Cotiviti account team to answer after today's 30-minute session. You can also use the Contact Us button to send an email to request additional follow-up. At the bottom, you'll find additional resources, including links to useful assets related to today's webinar. Click the images on your right to view a blog written by today's presenter after the most recent release of HEDIS tech specs, or register for our sister series to Quality Decoded webinars reviewing risk adjustment essentials throughout the year. And please use the Request a Demo button to get a more in-depth demo of any of our solutions. At this time, we do not provide copies of our slides, but a link to the on-demand recording will be sent to registrants and attendees within a few days. Finally, please take a moment at any point during today's webinar to answer our quick survey. Your feedback is extremely valuable and will help determine future topics for our webinars. Now, let me introduce our speaker. Samantha Davis is the Senior Manager of Program Management here at Cotiviti. With more than a decade of experience working in HEDIS, her team of HEDIS and state and custom program managers are accountable for ensuring adherence to NCQA and state Medicaid specifications. She's primarily responsible for bridging her knowledge of HEDIS and CMS requirements to inform the product roadmap, operations, and client collaboration, guiding our organization through the annual HEDIS update cycle. I'll turn it to Samantha to get us started.
Thank you, Cassie. So in today's webinar, we will review NCQA's notification of changes for HEDIS, step through the proposed measure changes for 2026 from CMS and 2027 for NCQA, analyze the new measures proposed for 2027, and then end with recommendations for next steps on the public comment materials. With the annual public comment in February, NCQA provides an extra document detailing finalized changes which are not up for comment. This year's notification of changes for HEDIS covers 3 measurement years worth of announcements. In the March 2026 Volume 2 technical update, NCQA will be adding LOINCs to the high-risk HPV lab test value set for the cervical cancer screening measure to incorporate self-collected samples. NCQA also reiterated a change to the social needs screening measure, which they first announced in a blog post last December. Due to code updates from the 2026 physician fee schedule, NCQA is retracting their addition of a new HCPCS code from the screening numerators, as well as removing ICD-10Z codes from intervention denominators. The measure will return to relying on LOINC survey codes and LOINC answer responses for measurement. NCQA also announced some changes to their planned phase-out of hybrid reporting. For 2027, the weight assessment and counseling for nutrition and physical activity for children and adolescents measure will no longer transition to administrative-only reporting. WCC will remain hybrid until 2029, where it will retire in the same year that a replacement measure is introduced, with no overlapping year for comparison. The 2027 Volume 2 specs will be releasing on August 3rd this year. NCQA will also be transitioning their long-term services and supports specifications to their FHIR-based spec layout, though this change will not impact the case management review reporting method of these measures. Continuing the hybrid transition changes, the prenatal and postpartum care measure will also no longer be moving to administrative only in 2028. NCQA is instead going to introduce a new replacement ECDS and risk-based measure in 2028, while simultaneously retiring the hybrid PPC measure with no overlapping reporting year. The transitions of care and care for older adults replacement measures have been delayed now to 2028, with 1 year of overlapping optional reporting before retiring the hybrid measures in 2029. Additionally, in NCQA's move toward digital measurement from clinical data, they're now planning to allow use of denied claims in 21 measures that have previously excluded them, including 10 overuse and appropriateness measures, a utilization measure, and all risk-adjusted utilization measures. NCQA also notes a plan to provide more specificity on data source identification and timing of measure requirements in the 2028 Volume 2 measure specs, with new and reevaluated measures going forward. They're planning to show an advanced preview of these specification additions at a later date. Switching gears now to the changes that are up for public comment, let's review the proposed measure updates from CMS and NCQA. On February 12th, CMS published their draft call letter of proposed changes to the Quality Rating System Exchange Reporting Program for measurement year 2026. Feedback on these changes can be submitted via email to CMS until March 20th. Aligning with NCQA's measure retirements, the QRS program will be removing the asthma medication ratio and medical assistance with smoking and tobacco use cessation measures. CMS is proposing to replace these retired measures with two new HEDIS ECDS measures: follow-up after acute and urgent care visits for asthma, and tobacco use screening and cessation intervention. They also plan to remove the childhood immunization status and immunization for adolescents measures, citing this change as alignment with agency priorities. While not mentioned in the call letter, we're also seeing indications from NCQA's measure certification program that the QRS measure proportion of days covered may transition from being a single measure with 3 reported rates to now being 3 separate single rate measures. On February 13th, NCQA published their public comment proposed changes for measurement year 2027 and are requesting comments be submitted by March 13th. NCQA would like to expand the eligible ages for the pneumococcal indicator of the adult immunization status measure from ages 65 and older to now 50 and older, with 2 age stratifications. This change aligns with updated recommendations from the CDC and American Academy of Family Physicians. NCQA is also looking to expand the emergency department utilization measure into the Medicaid product line. Medicaid reporting for EDU would be limited to ages 18 to 64 with 3 age stratifications. Members who are dual enrolled in commercial Medicaid or Medicare Medicaid would not be included in Medicaid reporting. Medicaid enrollees with 9 or more emergency department visits in the measurement year would be excluded as outliers. The final proposed change from NCQA is a redesign of the pharmacotherapy management of COPD exacerbation measure. They propose changing this measure from being based on a count of COPD exacerbations to instead be based on a count of members with qualifying exacerbation events. Members would be eligible for the measure if they have 1 inpatient stay with COPD or 2 emergency department, urgent care, or outpatient visits with COPD between January 1st to November 30th of the measurement year. NCQA proposes a new exclusion to this measure for 2 diagnoses of asthma in the measurement year or prior year on the same or different dates of service. We included a blue speech bubble icon on the slide to indicate a recommended topic for your public comment response. There's a high likelihood that a single event can be present within multiple data sources, such as having an asthma diagnosis present on both a claim and a clinical record. Determining whether 2 asthma diagnoses from different data sources on the same day or from the same event or different events can be complex. We'll be encouraging NCQA to reconsider including same-day diagnoses in this exclusion, given these data source complexities. The measure also reduces from 2 rates to 1 rate, measuring now for members who had at least 1 short-acting and 1 long-acting COPD medication anytime in the measurement year. Now let's review the 7 additional measures NCQA is proposing to add to measurement year 2027 reporting. The first new measure looks to capture the percentage of members ages 18 to 75 with diabetes that have evidence of continuous glucose monitoring utilization in the measurement year across all product lines. This would not be measuring performance, but instead would be documenting utilization of glucose monitors in the diabetic population. Members would be eligible for the measure if they've been diagnosed with diabetes and if they have evidence of using insulin, either due to a type 1 diabetes diagnosis or insulin medication. The measure would use the same exclusions as other HEDIS diabetes measures. Utilization of a glucose monitor has several different value sets for identification, including LOINCs for a glucose monitor observation or summary report, HCPCS and SNOMED codes for a glucose monitoring device, or RxNorm and NDC codes for a glucose sensor prescription. NCQA notes concerns that evidence of glucose monitoring within real-world data sources may be missing, incomplete, or located in unstructured formats, making it difficult for health plans to use for reporting. We recommend using the provided value set directory to analyze your HEDIS repository for the presence of glucose monitoring codes when providing your feedback to NCQA. In addition to age, race, and ethnicity stratifications, NCQA also proposes a stratification on whether the member has a diagnosis of type 1 diabetes. The next measure looks to capture the percentage of members aged 45 to 85 who received a colonoscopy after a positive colorectal cancer non-invasive screening test across all product lines. A member would be eligible for this measure if they have at least one positive stool-based colorectal cancer screening test result from July 1st of the prior year through June 30th of the measurement year. Once again, NCQA's feasibility analysis notes that stool-based test results are not often captured in coded discrete fields, impacting reliability and usability of the data. The value sets for test result identification require a LOINC test code alongside a SNOMED qualifier code, representing results such as positive, present, detected, etc. We recommend reviewing your data for the availability of these SNOMED qualifier codes, as well as providing feedback to NCQA on any lift your test result mapping efforts may require for the measure to be able to calculate eligible events accordingly. NCQA proposes several standard HEDIS exclusions for the measure, but for some of these exclusions, they're proposing non-standard timeframes. They've expanded some of these exclusions to look back into the second half of the prior year as well. A member would be compliant for the measure if they have a follow-up colonoscopy on or within 180 days following their earliest positive stool-based colorectal cancer screening test result. The next measure evaluates the percentage of members aged 12 to 64 who were screened for intimate partner violence using a standardized instrument, and if found positive, who received follow-up care within 7 days for commercial and Medicaid product lines. NCQA questions whether Medicare should also be added, noting small sample sizes during measure testing. All members who meet the age and continuous enrollment criteria would be eligible for the first denominator, with proposed exclusions for deceased and hospice. NCQA is considering removing the deceased exclusion in an effort to identify potential missed opportunities for IPV screening and follow-up. Members would be compliant for the screening numerator if they have an IPV screening with a documented result between January 1st and December 24th of the measurement year. Screenings are identified by LOINC questionnaire codes alongside LOINC answer responses or associated total score values. Following the trend of the other proposed measures, NCQA's analysis indicates that these questionnaire codes and response values are not often present in structured fields and are more likely to be located in free text areas, if present at all, in the EHR. The value set directory is a great resource to evaluate your current data feeds for the presence of these codes and comment accordingly. For members with positive screening findings, they would need to receive follow-up care on or within 7 days of the first positive screening. The IPV procedures value set includes a handful of HCPCS G codes and several SNOMED codes for services such as referrals, support, and education. In addition to an age stratification, NCQA is also recommending an administrative gender stratification for this measure. Next, we'll review a set of 3 person-centered outcome measures NCQA is proposing for Medicare C-SNP and D-SNP benefit packages. These 3 measures would evaluate the percentage of members 18 and older with a complex care need who set a person-centered outcome goal, followed up on the goal, and achieved the goal. All utilize the same initial population criteria and exclusions, requiring continuous enrollment from August 1st of the prior year through the end of the measurement year. Exclusions include the standard HEDIS events for deceased, hospice, I-SNP, or living long-term in an institution, but similar to other new measures, the time frames for some exclusions are expanded to include a portion of the prior year as well. The first measure for goal identification would consider a member to be compliant if they have a goal documented between August 1st of the prior year through July 31st of the measurement year. This would be calculated by the presence of a goal attainment scaling or patient-reported outcome measure LOINC with a populated goal domain on the same day, as well as a LOINC or SNOMED code indicating a care plan was documented within 7 days of the goal. The concept of a goal domain is new for HEDIS reporting. NCQA notes that goal domains do not all have terminology standards available, but they're in the process of submitting standard LOINCs for these domains, which they expect to be formalized prior to the measures being included in HEDIS reporting. The second measure for goal follow-up requires a member to meet both the numerator criteria for goal identification as well as evidence of goal follow-up in the 14 to 180 days following goal identification. For GAS goals, the member would need to have a goal LOINC and a score LOINC answer from both the practitioner as well as from either the patient or the caregiver documented on the same date of service. For PROM goals, the member would need to have a goal LOINC along with an associated total score value documented using the same PROM instrument as the baseline goal. As with the theme of these new measures, NCQA notes that goal tools and score results are not consistently documented in structured fields available to health plans, as well as potential accuracy challenges for tracking goal progress over time. You can use the value set directory to analyze the availability of this data in clinical system data feeds for your public comment feedback. The final measure for goal achievement requires the member to meet the numerator criteria for goal identification, as well as evidence of goal achievement in the 14 to 180 days following goal identification. Goal achievement follows a similar process to goal follow-up. However, when analyzing the GAS or PROM scores, a specific result must be present to represent that the goal's been met. For GAS goals, that would include a LOINC answer code representing a score of expected, better than expected, or much better than expected outcomes. For PROM goals, the total score value compared to the baseline score would need to have anywhere from a 3 to 5 point increase or decrease in score, with each PROM instrument having a specific meaningful change metric associated. NCQA asked for comment on whether this third measure should have public reporting delayed to measurement year 2029 to allow for additional time to monitor performance. The final new measure evaluates the percentage of deliveries screened for syphilis during pregnancy, and if screened positive, that received appropriate follow-up care for commercial and Medicaid product lines. This delivery-based measure is expanded to include both deliveries and miscarriages at 14 or more weeks of gestation between December 15th of the prior year through December 14th of the measurement year, with continuous enrollment from 30 days prior to delivery through 17 days after. NCQA notes that the measure should deduplicate multiple deliveries within a 26-week period, which may not be aligned with the event criteria to include miscarriages as early as 14 weeks of gestation. Exclusions for the measure are expanded compared to standard HEDIS exclusions. Both the hospice and palliative care exclusions evaluate the prior year along with the measurement year. Additionally, NCQA did not include the pregnant person's death as an exclusion for this measure. All deliveries meeting eligibility are included in the first denominator, with compliance based on whether the member had a syphilis screening with a reported result during one of a couple different time periods. Compliance screening timeframes include any time in the first trimester or any time from pregnancy start through 14 days after the first pregnancy diagnosis or first prenatal visit, or any time from pregnancy start through 30 days after plan enrollment. Screening and result values are identified by a LOINC test alongside a SNOMED qualifier result value, similar to the colorectal cancer screening result mentioned earlier. This measure, like the others we've reviewed, has the same issue noted in measure testing for data availability. NCQA was not able to successfully perform measure rate analysis for this measure due to the lack of SNOMED syphilis screening results in structured data fields. NCQA asks in the public comment if plans may have access to syphilis screening results, which could be mapped by the plan to SNOMED codes for measure processing. This shows how even with moving toward digital measurement using industry standard data formats, plans may still need to perform data transformation on electronic data feeds to make them usable for HEDIS measure calculations. Deliveries with a positive syphilis screening are included in the second denominator and would be considered compliant from either a negative confirmatory syphilis screening result on or within 5 days of the first positive screening, or evidence of penicillin treatment on or within 14 days of the first positive screening. Now that we've reviewed the upcoming, finalized, and proposed changes, what should you do next? If you haven't already, be sure to review the public comment materials from CMS and NCQA posted to their corresponding websites. NCQA's public comment webpage has a link at the top called All Public Comment Materials, but that link only provides the PDF content for the measures and does not include the proposed value set directory Excel document. Be sure you also separately download the value set directory from a link farther down on their public comment page to not miss this critical supporting documentation for evaluating measure feasibility. If you haven't already done so, be sure to submit your NCQA public comments by March 13th and your CMS quality rating system comments by March 20th. Over the next couple months, you can use the information from the technical update releasing on March 31st to locate and map data sources for cervical cancer screening self-reported samples. Additionally, you can use the Public Comment 2027 Value Set Directory to analyze early for potential data gaps. Once the Measurement Year 2027 Volume 2 specifications release on August 3rd, review them early. Even though you'll be concerned at that time about preparing for Measurement Year 2026, it will also be important to develop your plan to support proactive gap closure and data capture in calendar year 2027. You can join me back here on September 10th for a review of which changes and new measures were finalized in the 2027 Volume 2 tech specs, where I'll provide additional recommendations on areas of focus for 2027 preparation. Now I'll pass it back to Cassie to review the upcoming webinars in our Quality Decoded series and close us out.
Thank you so much, Samantha. Great information. Before we close, as Samantha said, here is the schedule of our other webinars in the Quality Decoded series featuring Samantha and some other experts from Cotiviti's Quality and Stars team. If you haven't already, you can register for any or all of the rest of the series. We'll be back in April after CMS's final rule publication, and Samantha will join us again in July for our annual end of HEDIS season review, and as she mentioned, the tech specs review in September. Lastly, if you submitted any questions during today's presentation, your Cotiviti account team will follow up as appropriate. You can also send an email at any time to answers@cotiviti.com with additional questions or for more information. This concludes today's webinar. Thanks so much again to our speaker, Samantha Davis. We'll be reaching out to you via email shortly with a link to the on-demand recording of the webinar. And as soon as this session ends, you'll have an opportunity to answer a survey about your experience today. Once again, I'm Cassie Yazzo. Thanks for joining us today, and we look forward to seeing you again soon.